So in this time of elections, psoriatic arthritis in the community, should everyone be referred? Yes, or maybe no, or maybe. Or really, I'm not going to answer the question at all. As you find on politicians, they're asked this every morning, you think, oh, why don't they just answer the question? Well, I might answer it as we go through. So this is what I'm going to talk about. It looks a lot, but it isn't. But it should just get us through to your ultrasound session. So first of all, the poor relation. And some of the data for this comes from the National Early Arthritis Audit that's done throughout rheumatology secondary care centres in the UK. So people with early arthritis, rheumatologists or whoever fills the form in, and they're followed up for a short time. And we have data on rheumatoid arthritis, obviously, and psoriatic arthritis. This is the data I'm presenting here, the rheumatoid arthritis in orange, psoriatic in blue. And on the left, you'll see the time to presentation, referral and diagnosis in weeks. And you'll see that the blue bars are a bit longer than the orange bars for symptoms to presentation, presentation to referral, I can hardly see this, presentation to diagnosis and symptoms to diagnosis seem longer for psoriatic arthritis than rheumatoid. And when they get to the hospital, this sort of gold standard of dual therapy is much more commonly prescribed to rheumatoid than psoriatic arthritis. Although monotherapy with methotrexate and sulfasalazine is more commonly prescribed to psoriatic arthritis. And amazingly, about 12% in either group don't get any treatment at all, despite having high disease activity. So why are the delays longer in psoriatic arthritis? Well, there's a long-standing perception that psoriatic arthritis has less impact than rheumatoid arthritis, and I'll come back to that. And I think there's probably less joint burden in PSA at the outset. We've got data from Leeds that shows you have a lot more oligoarthritis with psoriatic arthritis than rheumatoid. I think patients don't present to primary care because they're unaware of the risk of the association between psoriasis and arthritis. And because it's oligoarthritis, it's lower grade, so they're less concerned about it. And there's some evidence that it's palindromic as well. And as John has said, only half the cases have raised inflammatory markers, so if a CRP is done in primary care and it's normal, there may be a perception that it isn't arthritis or inflammatory arthritis anyway. We don't have serology in PSA like rheumatoid, although I think that may be on the way with current research. And psoriasis may not be obvious either. It's quite often hidden, so the patient may not know they've got psoriasis either. And I'll show you some data on that in a minute. So first of all, about the impact, and this is data from secondary care that we collected 20 years ago in Bradford, in people with psoriatic arthritis in the dark blue and rheumatoid arthritis in the light blue. And you see on the left there, those are figures for the amount of damage seen on the joints, much more in rheumatoid than psoriatic arthritis. But on the right is the impact of the disease, and virtually equivalent scores for physical function, pain, and quality of life in the two diseases. And what I'm not showing here is data on the severity of the psoriasis, because clearly that does contribute to quality of life and physical function, surprisingly. So it's an impactful disease equivalent to rheumatoid in secondary care, the ones that get into secondary care. So psoriasis, as I said, is sometimes not obvious, either to the physician and sometimes to the patient. That's because it can lurk in areas that you can't see. When you see your bottom, people can sometimes see their umbilicus. Not always. this is one reason I get into trouble, because when patients present to me, I make sure I look in all these places. And I was known for a while as the bottom doctor in Bradford. That's among my trainees, I might add, not the patients. But also, on the foot, if you don't take the shoes and socks off, you'll miss the pustular psoriasis on the foot, behind the ear and on the posterior hairline. Very common sites for psoriasis. In the ear is a common site, the umbilicus and the natal cleft we've just seen. But the groins and the armpits, common sites for flexural psoriasis. And I'm not showing pictures, because it's early in the morning, well, maybe not, of the genital psoriasis you can get. But that isn't also quite a common problem in men and women. And also there's nails, of course. And we don't always look carefully at nails. And the two commonest signs are onycholysis and pitting. So we miss it as physicians, and there's good evidence in the Netherlands to support that, unless we look for it. And to look for it, we've got to take the patient's clothes off. And patients aren't always used to getting their clothes off these days, particularly when it's the middle of winter and they've got a lot of clothes on, several layers. So there's a time factor involved in that. So to support my assertion that patients don't often know they've got psoriasis is some data we collected in Leeds last year. This is a community bus, as it were, or ambulance, that we parked in the middle of Leeds in the middle of December last year. It was very cold and windy, but people were out Christmas shopping, and we invited them to come along if they got a rash that they thought was psoriasis. Well, they didn't know, but if they got a rash, essentially, so they would be shopping for their Christmas presents and think, oh, I've got a bit of a rash, free consultation. It got very cold. You can see people wrapped up here. So we advertised this in the local social media to improve attendance. And if they came, we took them into the bus, we looked at them, and if they'd got psoriasis, we asked them lots more questions as well. But over the course of 5 days, we had 300 people turned up, of which 140 did have psoriasis. And of those, 82, it was a new diagnosis. So we thought, the patient said, oh, I didn't know this was psoriasis. But, patients are fickle things. And we've shown that before with back pain, that they may have seen the GP who said, you've got psoriasis, and forgotten. But 82 said, oh, no, I didn't know I got psoriasis. So it's not uncommon. We also asked about patient satisfaction, and here's a little bit of primary care beating going on. But obviously they were coming because they weren't happy with, either they were curious or they weren't happy with the way that their rash was being looked at or treated. So only 26%, that orange bar, said that they were satisfied with their care. And the reasons for dissatisfaction were lack of appointments in primary care, treatments that didn't work, COVID, embarrassment, of course, and various other reasons. So these were a slightly unsatisfied population, which were more likely to turn up, obviously, and knock on the door of the bus in the middle of Leeds in December. So coming back to PSA, is there a window of opportunity by like in rheumatoid arthritis, there's evidence if you treat earlier, you get better outcomes. And does the same window exist in PSA? There's observational evidence to suggest it does. There's evidence from Dublin and Toronto. This is the Dublin evidence. This is looking at a case review of patients in the Dublin cohort, looking back right to the start of their case, how long it took them to get referred into rheumatology. And they used an arbitrary cut-off figure of 6 months, and then they looked at this group 20 years later on average to see how they were doing. And if you were referred longer than 6 months from your onset of symptoms into rheumatology, you were twice as likely to be functionally disabled and 4 times as likely to have erosions on X-ray at this later time point. This is an observational study, and there are all sorts of biases that might influence that result. So you can't take this as the truth. What you need is a prospective study, of course. And that's what I'm going to describe next. Is it worth screening prospectively to pick people up earlier to improve the outcome? And we've just completed a NIHR program grant called PROMPT to look at this. And PROMPT had various bits. The main RCT of early identification was called TUDOR, which I will describe in a minute. But there were other bits bolted on. That's what the NIHR like, as John has already described. But there was EPIC that looked at CPRD data, COMPARE that looked at the accuracy of screening questionnaires, COSPAR looked at cost effectiveness, and there was some qualitative work and outcome work as well. Looking at, just focusing on EPIC, which is the risk factors for development of psoriatic arthritis if you have psoriasis, what was already known that there are, and none of these are blazingly discriminatory, like, say, rheumatoid factor or CCP. But there are genetic biomarkers such as B27 and IL-13 that are more associated with the development of PSA. There are other biomarkers that are now coming online but are not yet in clinical use. Ultrasound evidence of subclinical enthesitis may be a risk factor. There's evidence that trauma is an early symptom and a rapid onset of the early symptoms. If you've got nail disease and you've got scalp and flexural psoriasis, you're perhaps more likely. And if you have comorbidities, you're more likely. And lifestyle factors such as obesity, smoking, and alcohol are also important. And these really are the modifiable risk factors. Maybe the others aren't. But these are the ones we should be thinking about, the lifestyle factors. So there's already good evidence that obesity is a risk factor for the development of people who've got psoriasis. There's some evidence that alcohol may be a risk factor, but the smoking is a bit conflicting at the moment. So you can't say that's a hard and fast modifiable risk factor, as it is, for instance, for rheumatoid arthritis. So this is a long way of saying what we found in the PROMPT study from the CPRD data. So this was looking at GP practice data from over a 20-year period. So, and we'd got from that data data on BMI, right, 20 years ago now, and the risk of developing PSA. And what Millie Green, who did this part of the study, was able to show us, if you lost weight during that period, if your BMI reduced, then you were less likely to develop PSA. So your risk fell if you lost that weight. And this chart shows that. So the current BMI is on the x-axis, and the BMI 10 years ago is on the vertical axis. So if you've gained weight during that period, you're in the red period, boxes here. If you've lost weight, you're in the green boxes. And the change in risk is quite substantial. If you'll see at the bottom there, the dark green represents a 30% drop in risk if you lose about 5 off your BMI during that period. And at the other end, the dark red is 30% increased risk. So this is really one very modifiable risk factor for people who've got psoriasis who may be worried about developing PSA. But really, this study was all about, does early detection improve outcome? So we had a cluster randomized trial. We've just heard about those from John. And in one cluster, there was enhanced surveillance of people with psoriasis coded on the GP record. In the other side of the cluster, there were people who just had standard care. And the enhanced surveillance had a baseline assessment by secondary care doctors, rheumatologists, or clinical nurse practitioners, sometimes physiotherapists, and were followed up with similar assessments at 12 and 24 months. And the routine standard care group just had questionnaires until the final assessment, when they were also seen. And the primary outcome was the health assessment questionnaire, which is a physical function questionnaire compared at 24 months between the two groups. It's a big study. There were 2,300 people in this study across, I think, Bath, Stoke and West Yorkshire were centres. And we were all very optimistic that we were going to make a difference here, but the primary outcome showed that there was no difference in the HAQ scores between the groups at 24 months. But there were lots of caveats, as there is with any study. We didn't get as many cases of new onset PSA as we expected from previous data. There was lower prevalence than we expected as well. We only found 6.2% rather than the 18% that's published. When we did identify people early and sent them into secondary care, it took ages to get a diagnosis for whatever reason. And of course, it was all in the middle of COVID, so there were delays built in as a result of that as well. So I would say it was a negative study, but it's not a negative answer, really. I think the answer still does need to be sought for that question: does early identification improve outcome? And this little diagram I borrowed from Anne Barton just shows the sequence of events that we're talking about here. We have on the left a healthy at-risk population, at risk of psoriasis, that is, who may develop psoriasis, and we know that there are genetic influences on that and environmental influences. And then of that group of psoriasis, about 20% will develop psoriatic arthritis. And we know there are genetic and environmental factors that influence that as well. What we'd really like to do is screen the group of people with psoriasis for those who are going to develop psoriatic arthritis to identify and treat them earlier. What we actually do at the moment is pick up prevalent cases of PSA in people who have already got psoriasis. And we do that by using screening questionnaires, which were used in PROMPT and TUDOR. There are lots of these out there. Of course, we recommend the PEST because we think it's best, and it was developed in Leeds. And it's just 5 questions. And this may be a pop-up as well, I don't know. We'd like it to be a pop-up. Patient with psoriasis comes in to consult, pop up the PEST, and it's easily compared. It's easily completed, sorry. Is it any better than the others? Well, we did a study just to compare the PEST with 2 other of the others that are available, the PACE and the TOPAST, in secondary care. So all patients were given each of 3 questionnaires in random order, and we examined all the positive responders. Again, this was a big enough study, about 1,000 patients, 200 examined, of which a quarter had new diagnosis of psoriatic arthritis. Prevalent cases, not incident. Was the PEST any better? Well, the crucial statistic here is on the bottom line. That's the area under the receiver operating curve. The bigger the number there, the better the discrimination of the test. Those numbers, although the PEST has the highest AUC, statistically it wasn't any different to the others. And there's probably very little difference. So I always recommend using the simplest questionnaire, which I think still remains the PEST. But you will find lots of other rheumatological diagnoses in there. If you get a positive test, you might have osteoarthritis, you might have fibromyalgia. If you send everyone with a positive test to your local rheumatologist, you're not going to be very popular. And I think we're asking too much of screening questionnaires, because if you look at the diversity of phenotypes of psoriatic arthritis, there's no way a simple questionnaire is going to identify across that spectrum of disease. And as I said, the patients aren't aware of the association either, although I think that is improving. And we therefore developed a leaflet for patients, which you see here, to try and improve their responsiveness to primary care surveillance studies that we were doing. And in one such study, half the people were sent the information and half the people didn't get it. And we looked at the response rate to coming in for the surveillance exam based on whether they got the leaflet or they didn't. And it was quite interesting, really. We had 5 general practices we did this study in, 3 of which were in posh areas, Addingham in West Yorkshire and Haxby in York. But there were a couple of less posh areas, one being Keighley, where I live, very high social deprivation, and the other is Acomb in York. And the only places that this leaflet had an impact, really, was in those 2 areas, Keighley and Acomb. So maybe there is a use for educating our patients as well, but it's in some areas patients are already up there and know all about it. And so the question about impact I'd like to come back to in the final few slides. And as I've already said, people present with psoriatic arthritis have usually got less joints involved than people presenting with rheumatoid. And about 50% at presentation have what's called oligoarthritis, less than 5 joints involved. Some, about 10-15%, have monoarthritis, just 1 joint involved. And this work from the Netherlands has looked at the impact on quality of life of whether you've got a single joint, less than 5, or multiple joints. And this is a spider diagram of the SF36, the health-related quality of life outcome measure. So the normal population are in grey. And the worse your quality of life, the more shrinkage of your points you have. So if you were right in the middle, you'd have terrible quality of life. You're right on the outside where the grey is, your quality of life is equivalent to the rest of the population. And it's true that the polyarthritis group of psoriatic arthritis have the worst quality of life across the board, but the oligo and mono aren't so far behind. They're less, but not so far behind. So they can be quite impactful, just having a few joints in this disease. And data from that Tudor prompt study I've just been describing, of those identified by enhanced surveillance, it was mostly oligoarthritis, mostly low-impact disease. So these are prevalent cases of psoriatic arthritis out there in the community who are not presenting to their GP or whoever, who are living with their oligoarthritis, as it were. So the median tender joint count, only 4, median swollen count, only 2. And the median HAC, that physical function questionnaire, was minimal, really. So I think there are people out there that we don't see, you don't see, who are managing their condition and are happy to do so. If you do get them into secondary care and we say, oh, you need a DMARD, the dreaded methotrexate, they say no. And I know this because the study that Laura Coates did in Oxford, this was particularly focused on oligoarthritis, people who haven't got poor prognostic factors such as a raised CRP and so on. But over a 2-year period, they only got 1 patient into this study because they were reluctant to go onto these horrible disease-modifying drugs because they weren't that bothered about it. I have to mention the foot because it's one of my special interests, but it's a common site for the onset of PSA, and I think we're very poor at examining the foot and ankle. We run a foot and ankle course in Leeds, and we have done for the last 25 years, and people come, they're absolutely, completely ignorant of anything to do with the foot and ankle. There is a phobia about the foot and ankle. That we have a session on that at the Leeds foot and ankle course now, but I'm not going to go on about that. But here's a case to just an example of that. So this was a chap who was a company director, high-flying businessman who came to see me because he'd got a painful, swollen big toe. It wasn't gout. We excluded that. The toe stopped him playing golf, where he did all his business, or a lot of it. He had psoriasis for many years, and NSAIDs hadn't helped, and there's a picture of his toe. Basically had a swollen, painful interphalangeal joint, and he had a nail dystrophy in the same toe, a little bit of new bone formation. And this is called a Bowers digit. So this is a monoarthritis presentation of PSA. Not that common, but common enough to get the acronym Bowers digit. Who was Bauer? Walter Bauer. His obituary, he was working around the war period in North America. He actually described psoriatic arthritis quite well years before Werner Wright did in Leeds. So he's got his name in perpetuity as describing the Bowers digit. Anyway, coming back to our company director, I didn't want to give him methotrexate. He didn't want methotrexate, stop him drinking. So he injected the interphalangeal joint of his great toe. Not an easy thing to do, but he got such benefit that he wanted it doing again, which we did. Then I lost him after follow-up. But he came back 2 years later, looking fit and tanned. He'd lost weight. He'd sold his business. He said he was fine. He'd been in Thailand, hiking in the jungles, and done press-ups every morning, and he was stung by a scorpion. He said, that got rid of everything. And it reminded me of traditional Lakeland treatments. I've come from the Lake District this morning, such as wrapping an eel's skin round the limb or soaking cod entrails in a bucket of toothache, rub the child's teeth with the brains of a hen. But if you've got arthritis, arrange to be stung by bees or scorpions. That'll do the trick. Here's another monoarthritis case. This is not uncommon either. People who have got a swollen knee, spontaneous onset of a swollen knee, they go to orthopedics first off, and then they come to us when the orthopedics do an MRI scan and show a lot of synovitis and no torn meniscus. So this man came down that route. He'd got psoriasis. As you can see, his cousin had psoriasis. His knee had been swollen for 3 years. He'd actually had an arthroscopy, which showed synovitis. And like all the biopsies they do, it showed compatible with rheumatoid. Didn't make any help at all. So he'd got a big knee, got psoriasis, no other joints, no comorbidities. X-ray was normal. But he told me he worked, when you go to EULAR and ACR and EADV, he puts all the stands up. So he's there for a couple of weeks before we go, and then he drinks beer for 5 days or whatever, and then he takes them down and takes them home. So we had a bit of connection, this man and I. He didn't want methotrexate either. So I gave him a steroid injection, helped, and I did that 3 times. And then he agreed to start methotrexate because he was fed up of getting it injected, but it didn't help him. Ultimately, I had to do a radiation synovectomy, which gave him a little bit of relief. And then he was lost to follow-up. And then I bumped into him in an airport in Amsterdam on his way back from one of these conferences. And he says, oh, it's fine. Yeah, it's all sorted out, Doc, thanks. Psoriasis wasn't a problem either. So I think the point I'm trying to make with these cases and what I've said previously is that when you've got a few joints, there will be people out there who aren't too bothered about it and who are living with it. Of course, NICE doesn't give us any evidence at all to help us. It's all based on trials which are entry for a trial is polyarthritis essentially. It's 3 swollen and tender, but most have got about 18 tender and 15 swollen. So all the evidence is based on polyarthritis. Of course, oligo may develop into poly, and it does in 20 to 30% of cases. And we know that if you only got oligoarthritis, people don't necessarily want treatment with DMARDs. The single swollen knees are not uncommon with psoriasis. They're resistant to treatment. They respond very poorly to DMARDs, usually. And they don't necessarily damage your joint. So I've seen a young girl who was 15 who came with her big knee, and I see her now in her 30s, and she still doesn't have any damage. She's still got a big knee, but no damage to it. So it's not like rheumatoid where it's always going to lead to erosive damage. So just finally, comorbidities. I had to mention that. There are lots of comorbidities, psoriasis, psoriatic arthritis. There are true associated conditions such as uveitis, inflammatory bowel disease, and so on. But you see a lot more obesity, as we've said, diabetes, metabolic syndrome, and there's a much higher risk of cardiovascular disease. All things we should be thinking about screening for in our patients. And these very nice studies from the NIH in America, when they first came out using PET-CT, where they were able to show so nicely where all the inflammation is in a patient with psoriasis. Well, this was a psoriasis patient, but they were able to show subclinical inflammation in the knee. You can see inflammation in the psoriatic plaques of the legs there. But interestingly, inflammation in the arterial system, which was a revelation to the people doing this. And also, according to what they say, there's inflammation in the liver as well. So the inflammation is not confined to the skin and the joints, it's systemic. And this will lead to the outcomes we've just discussed, with higher cardiovascular risk and so on. So this is recommendations from the US, but we follow these reasonably carefully in our patients with psoriatic arthritis. We do regular blood pressure, body mass index, waist circumference, fasting lipids annually, and glucose every so often. The question is, what do we do about this? If we find the raised lipids or the raised blood pressure, is it our responsibility to treat this, or do we send them out elsewhere to be treated? And this is, most of my colleagues do the latter. Oh, you've got high lipids, I'll send you to your GP to get this treated, or high blood pressure. This doesn't always happen, and I think there's a great need to get better coordination between primary and secondary care in addressing these important factors in this disease. Rheumatoid the same, of course. So let's answer the question finally and not be a politician. Should everyone be referred? I think probably no, for the reasons that we've already just talked about. But there are specific groups where referral should be made, particularly polyarthritis. They're the ones that are going to get the erosive disease. Dactylitis is a severity marker. Axial disease, important to treat. We heard from John. And bad skin. We're not dermatologists, but we've got roots into dermatology via combined clinics that will address. And the drugs we treat the arthritis with will help the skin as well, methotrexate in particular. And so I think the less impactful cases perhaps shouldn't be referred necessarily unless their skin is a problem. I think there's a limitation with screening questionnaires. They pick up prevalent cases, but they pick up a lot of other stuff as well. But they do have a role, I think, in flagging this association. And I think we have to sort out who's going to treat the comorbidities as well. So I have answered the question, I think, and I'm happy to answer any others if you've got them.
Thank you for that. So I don't think I was quite concentrating. What's the problem with dactylitis? Why is that?
Oh, I didn't show any evidence, but dactylitis is a severity marker for PSA. Yeah. So if you've got dactylitis, you're likely to get erosions and subsequent functional problems and so on.
And do you get dactylitis with osteoarthritis or rheumatoid? Because often you see gentlemen in their 60s with fat fingers in clinic, and it's hard to tell.
No, you don't, but there are mimics. You get dactylitis in sarcoid, which is less common, of course. TB, also less common. Leprosy. But gout will give you dactylitis sometimes. And trauma. I mean, I've fallen foul of this, people dropping stuff on their foot and coming to me in clinic and saying, with other problems, and I say, oh, I know what's wrong with you, you've got dactylitis. Well, I dropped something on it yesterday, Doc. But yeah, dactylitis, definitely.
It's a marker, yeah. Any questions? So, John, have you got the microphone? Thank you.
Thank you, Phil. That was a lovely talk. Really nice. When you talked about comorbidities, you didn't mention depression or mood.
I didn't, no. I should have done, of course.
No, I think it is a big problem, isn't it, that we see in a lot of our rheumatic disease patients, and we're rubbish at addressing it.
Indeed. Yeah, that should have been on the list. Mea culpa for that.
Sorry.
Thank you. Anyone else? Oh, she's gone too. No. I can't believe that. Come on, that was an amazing talk.
Well, I've answered all the questions.
You have, yes.
Anyway, it's nearly lunchtime.
Yeah, so there's an ultrasound workshop over lunch, and you should have been allocated to either the first session or the second. You don't have to go to that if you don't want. You can talk to colleagues, but it would be nice if you could. And thank you very much, Philip. As usual, that was a really interesting talk.
You're welcome.
Thank you.